Morning, good afternoon, everyone. Jonathon Leipsic here from Vancouver. I'm really honored to be moderating this webinar brought to you by SCCT and, of course, HeartFlow. I want to start thank the program sponsors from HeartFlow for their support, and also, of course, the great team at SCCT as always. Perhaps why I'm stumbling a little bit is because I'm humbled to be moderating the session. I have two of my esteemed colleagues and dear friends speaking with me, Dr. Ron Blankstein and Dr. Michael Gallagher, really two exceptionally thoughtful clinician scientists who've taught me personally so much over the last 15 years, really, perhaps even 20, as it relates to the integration of CT, understanding the possibilities of phenotyping atherosclerosis, and really managing patients. I think what we have for us today is not only exceptional imagers, but tremendous clinicians as well. So without further ado, I'll kick it off and try to share some of my thoughts. I'm going to focus less on atherosclerosis and focus on other opportunities around lessons learned as it relates to integration of artificial intelligence and machine learning in our clinical practice. In particular, I'm going to focus on FFRCT. As you know, there are now many opportunities around anatomical segmentation of coronary atherosclerosis, and we'll also hear from Drs. Gallagher and Blankstein around quantitation of atherosclerosis and as well anatomical lesions. But I'm going to focus on some of my personal lessons that I've learned from the integration of FFRCT over the last 7 years. I do have disclosures. As you know, we run a CT core lab in Vancouver for which I take no compensation, but I do give advice to HeartFlow and Circle Cardiovascular Imaging. So as I'm sure many of you know, at the SCCT, I believe in 2010, we were first exposed to the opportunities of integrating artificial intelligence and machine learning, as well as applying computational fluid dynamics to a resting CT to derive FFRCT without a change in protocol, without additional radiation, and without administration of adenosine. And importantly, the technology we saw at that time was one that allowed for point-specific physiological adjudication of pressure, lesion-specific pressure, focal pressure calculation distal to any individual lesion. And it's that information that we've learned over the last 15 years that is fundamentally important to informing medical management, informing the need for referral to the cath lab, and enriching the cath lab referrals such that patients who go to the cath lab are more likely to be intervened upon. When we look at the accuracy of FFRCT, I share this slide, and you may say, why are you sharing a slide 5 years ago, from 5 years ago? And the reason I am is really to share with you what I've learned over the last 5 years. If I were to have shared this slide 5 years ago, I would have focused only on accuracy, the accuracy of FFRCT compared to invasive FFR, highlighting that if the invasive FFR was 0.81 or above or 0.80 or below, FFRCT would be on the correct side of the cut point 87 times out of 100. But what I've learned over the last number of years is that accuracy is only one modest measure of diagnostic performance as it relates to what the clinician and what the interventionalist needs to know. When you look at the guidelines suggest that we should consider using FFRCT in a 40 to 90% stenosis. In a patient and a vessel, we would consider for revascularization to inform the decision around cath referral. But when we're informing that decision, we need to really understand what the interventionalist needs to know. She doesn't want to know if the LAD is likely normal or abnormal in a binary sense. She actually fundamentally needs to know whether or not the lesion itself is causing abnormal pressure, how abnormal the pressure is, and how the pressure falls off in relationship to the focal lesion. And that is why unique to FFRCT is the ability to compare the absolute value in a quantitative and statistical fashion, which in the setting of the NXT trial was excellent, 0.82. That means the absolute value agrees in an excellent fashion with the invasive measure. So we're not telling the clinician that the LAD is normal or abnormal, independent of where or the absolute value, but rather really isolating the lesion and telling the clinician that the lesion itself is causing abnormal pressure loss, and this is the absolute calculated pressure, and this is the pattern of pressure loss across the lesion. Now, that may be a lot of words that seem complicated, but at the end of the day, it's quite a simple concept. this concept that physiology has no utility as a binary tool. If we look on the left, you can see you have an LAD system where the pressure falls off in the distal diagonal. The LAD system is abnormal. That's a true statement, but there's nothing focally to treat with mechanical intervention. The lesion-specific physiology is negative. There's no focal drop across it, and rather you just have slow dissipation of pressure across the length of the LAD and the dual diagonal. On the other hand, on the right, you have focal lesions, and each lesion itself is causing focal pressure loss, with the absolute values distal to the focal lesions being abnormal. Both of these models are abnormal, but the one case on the right is a model that will derive benefit from referral to the cath lab for planning complex PCI or bypass, and the case on the left needs medical therapy. We've learned this over now the last 7 years. This is some of our original work highlighting the importance of isolating the lesion in informing the decision around cath referral. You identify a stenosis, Dr. Blankstein has read it, and the question is, will this patient derive benefit from cath referral or not? And to answer that question, he doesn't want to know if the LAD is likely normal or not. He really needs to know whether that lesion itself is causing abnormal pressure loss. And in this case, you can see the lesion itself is negative. Sure, the distal vessel drops below 0.8, but there's nothing focally to treat with mechanical intervention. And we now have 7-year follow-up data that will be presented, for example, at TCT, that highlights that managing patients based on the lesion-specific value is fundamentally helpful in informing the decision around cath and also informing decisions around downstream medical management. This has been shown, of course, not just observationally, but also in randomized trials. The PRECISE trial looking at the lesion-specific value informed decisions around cath referral in a fashion that drastically and statistically significantly reduced the rates of cath without obstructive disease by 70%, while improving the PCI to ICA ratio from 28 to 72% in this trial. Taken to an extreme, again, both of these LADs are abnormal. This is a true statement. Neither of them, I can assure you, none of these models are those of people playing in the NFL. But the case on the left, you see very slow dissipation of pressure without a focal drop. That patient needs medical management, despite the fact they have diffuse atherosclerosis and a stiffened or hardened artery. There's nothing focally to mechanically intervene. Whereas the case on the right, of course, has focal pressure loss with abnormal translesional pressure loss and a markedly abnormal lesion-specific value of 0.66. Finally, I just wanted to close on one of the things that we've learned as it relates to the pattern of pressure loss. You know, if we were to take a time capsule or go back in time to 2009 with the original randomized trials in the invasive space around FFR, we learned that physiology, as we've seen now repeatedly, should be used to, or should be considered to guide decisions around revascularization. Of course, now we know that invasive physiology is in the guidelines for the chronic coronary syndrome management, as well as for revascularization as class 1 indication. But what I've learned from our interventional colleagues over the last decade is that it's not enough to simply say again that the LAD is normal or not. We need to interrogate not only the depth of the pressure loss, but also the pattern of the pressure loss. As shown here from Dr. Collette, they've dropped a wire in the LAD and they're pulling the wire back, interrogating the phenotype of pressure loss across the length of the LAD. All 3 of these arteries in a binary sense are abnormal. They drop below 0.8 in the distal vessel. But on the right, the pressure falls off incredibly slowly across the length of the vessel. On the other hand, on the left, you can see that there's a focal drop of pressure across a focal lesion. This really will lend itself to mechanical intervention. And again, on the right, this will not lend itself to mechanical intervention. This is actually from the PPG Global study published recently by Carlos and his colleagues in Circulation. And again, you can see that both of these invasive FFRs on the top row are abnormal. In fact, the case on the right is significantly worse than the case on the left. But when you look at mechanical intervention, you can appreciate that focal pressure loss, as shown here in the top left, really lends itself to mechanical intervention, and the post-PCI FFR is significantly improved. On the other hand, on the right, you can see that the pressure loss is incredibly slow, and that despite the severely abnormal physiology, long segment mechanical intervention does not meaningfully change the pressure with a post-PCI FFR of 0.66. So over the last 7 years, we've learned that this is fundamentally important, and we keep this in mind as it relates to interrogating the vessels as we evaluate them prior to decisions around referral to the cath lab. All 4 of these LADs are abnormal. These are all abnormal physiological LADs with pressure loss in the distal vessel. But on the right, you see very focal phenotypes of pressure loss, really lending themselves to mechanical intervention. Whereas on the left, you see this diffuse pattern of pressure loss, again, highlighting an abnormal LAD, but an LAD that is unlikely to derive benefit from cath referral and PCI, uniquely ascertainable or able to be discriminated non-invasively using FFRCT. So I will conclude my few words. We'll pivot to atherosclerosis, but I just wanted to close with lessons that I've learned over the last 7 years, that essentially per vessel binary physiology has almost zero clinical utility in my practice. I can predict that the LAD is likely to have abnormal physiology in the distal vessel when I see diffuse disease in an anatomical lesion. My real question is not, is the LAD or the right coronary normal or not? My real question is, will this patient derive benefit from mechanical intervention of that focal lesion? And in order to do that, I need to localize FFRCT distal to the lesion. I need to interrogate the depth of the pressure loss, and I need to characterize the pattern of the pressure loss. All 3 of these elements are fundamentally important in guiding ICA referral and PCI planning, as we've seen now observationally with up to 7-year follow-up and in, again, 2 randomized prospective trials. So I'll stop there, and I will pivot over to a dear friend, Professor Blankstein, who comes to us, of course, from Harvard, from the Brigham and Women's Hospital, past president of the SCCT, current chair of the ACC Cardiovascular Imaging Council, but most importantly, an incredible friend and a very dedicated clinician scientist who's taught me and so many of us about cardiac CT as well as prevention. So without further ado, Ron, please.
Well, Jonathan, thank you for the very kind introduction, and always an honor to follow you and follow an outstanding talk. I'm going to talk more about plaque analysis. We'll kind of shift a little bit to plaque analysis. And one of the really exciting developments in plaque analysis is what we now call quantitative coronary plaque analysis, or QCPA. And I'll talk about the accuracy of that, and I'll show you an example. So as a background, one of several studies that really kind of set the tone and showed us the important prognostic value of quantifying plaque was the Scott-Hart study, and shown on this slide here is a very important study that was led by our colleague, Dr. Michelle Williams, where plaque was quantified. These are individuals in the Scott-Hart trial, which of course is a trial of patients with stable chest pain. And what we can see on the top slide here is the prognostic value of total plaque volume, the overall amount of plaque that individuals have. And in this study, patients who have the highest plaque volume have a substantially higher rate of myocardial infarction. And importantly, this is incremental or beyond risk factors, calcium score, or whether patients have stenosis. And that's a very important point to show that plaque analysis not just tells us who's at higher risk, but to show that it's actually incremental to other things we typically measure on CT. We then can characterize plaque, and there's different ways to do so, but one of the most common ways is to look at the type of plaque by looking at the Hounsfield unit and dividing plaque into non-calcified and calcified, and then the non-calcified plaque can be further divided into different types, with low attenuation plaque being specifically plaque that has a Hounsfield unit less than 30. And in this study here, Dr. Williams and our colleagues showed that low attenuation plaque had the strongest association with incident MI in the Scott-Hart study, specifically when individuals had more than 4% burden of low attenuation plaque, they had the highest risk. So important study showing us that plaque really matters, and quantifying it makes a difference when it comes to risk assessment. But of course, the big question is, how accurate is plaque quantification? Not just kind of tells us who is at risk, but how does it correlate with other techniques? And probably the best one, and what would be the reference standard, would be invasive techniques such as IVUS. And this is what's been done in the next 2 studies that I will show you. The first one here is the Miami study. So this is out of William Beaumont. It's a single center study where individuals who had a STEMI were recruited into the study. They had 2 invasive studies, but in addition to that, they had a coronary CTA, and that allowed the investigators the opportunity to quantify plaque and CTA and see how it correlates with invasive measures, specifically with IVUS. And the results are shown over here, and on the left, just to kind of walk you through this figure here, we have on the y-axis, the total plaque volume is determined by IVUS. On the x-axis, the total plaque volume is determined by coronary CTA. And what you can see is a very strong correlation here, an R value of 0.92. So 1.0 would be absolutely perfect. Nothing is, almost nothing is ever perfect, but 0.92 is a very strong correlation and impressive data. On the right side of this slide, further dividing this into different types of plaque. So not just a total plaque volume that has a correlation of 0.92, but calcified plaque and non-calcified plaque also was strong correlation. So this is a single center study, but if we now move beyond that, there is now a multi-center study, and I think a tremendously important study in the field, and that's the REVEAL Plaque study. This is a study that was conducted at 15 sites where plaque was actually measured both by IVUS and by CT, and this was a prospective comparison. It was done very well. Core Labs did this, so there was a core lab that measured plaque with IVUS, and of course also was CT. And on the left side here, you can see the correlation here, 0.91, so very similar to the Miami results, but now shown in a multi-center study showing very strong correlation when we look at plaque volume. And specifically, there was also good correlation when looking at the subtypes, looking at calcified plaque volume and non-calcified plaque volume. In this study, I would note the third correlation that was done was low attenuation plaque, and probably as expected, lower attenuation plaque, a little bit of a lower correlation than calcified and non-calcified plaque. And I think this is expected because the different threshold for low attenuation plaque, I think, vary, and there's, I think technically it's a more difficult measure to get. So how does this work clinically? How would we use plaque quantification? I wanted to show you one case, which I thought was interesting and instructive from my own institution. This is a coronary CTA of a 32-year-old male who has hyperlipidemia. Yes, LDL is high, 150 milligrams per deciliter, but more impressive is his elevated lipoprotein A, which is 230 nanomole per liter. To kind of give you a sense of what that is, the current ongoing clinical trials that evaluate therapies for lowering lipoprotein A are using a threshold of 200 or 175 to get into those trials. He was also a smoker, and he was referred for coronary CTA after he went to another hospital and had what was ultimately determined as a non-ST elevation myocardial infarction. He had some fairly nonspecific chest discomfort, but he was found to have a mild elevation in his troponin, so he was diagnosed with a non-ST elevation myocardial infarction. It was actually attributed at the time to the use of marijuana because that was also a complicating factor. So he is sent for a coronary CTA, and what we can see on this slide over here is the coronary CTA results. And specifically, if we look at the left, at the right coronary artery, the LAD and circumflex, we can see that he doesn't have any significant obstructive disease, really minimal plaque. Our eyes are always drawn to the calcifications, but if you look carefully, you may see, well, perhaps there's some non-calcified plaque. And overall, I think in most of our patients, this would be a small amount of plaque, perhaps when you're just kind of looking at these quickly. But of course, because he's young, I think it catches our attention. A 32-year-old really shouldn't have any plaque, ideally. And when we look at the images, we actually start to see some more plaque. But in this case, initially, we thought he had plaque. I don't think we were as impressed by the amount until we actually did a quantitative plaque analysis, and this was done by the HeartFlow tool that we're discussing today. And what we can see here when we perform that, this is the ultimate readout, is we can see for each vessel, left main, LAD, circumflex, RCA, the total plaque volume in cubic millimeters, and you can see that on the bottom. And then for each vessel and for the total, that's then divided into calcified plaque, non-calcified plaque, and low attenuation plaque, which again is a subtype of the non-calcified plaque. In his plaque volume, 824 cubic millimeters. That's a lot of plaque for anyone, but particularly for someone in his 30s. Now, how do I know that's a lot of plaque? Well, of course, when you start to quantify plaque, you kind of get a sense of these numbers. But if you're not sure, I think one area that's very useful is a nomogram. And Jonathon Leipsic actually helped develop this. And on this nomogram here, we can see the percentiles for these different curves across different ages. Now, of course, he's less than 40, so he's off the chart. And if I put this red star for his amount of plaque, which is 800 cubic millimeters, we can see he's like way above the 90th percentile. In fact, if you are young, even having more than 100 cubic millimeters of plaque would put you above the 90th percentile. He, of course, has, you know, tenfold the amount that would put him at the 90th percentile. So extensive amount of plaque. But not only is the amount of plaque is high, I think the other very interesting point here is that 90% of this plaque is non-calcified. We are always interested in who are the patients who are more likely to have non-calcified plaque. And probably the reason why this catches a lot of attention is because this is the type of plaque that's more modifiable. It's a type of plaque that perhaps we can regress with our therapy. So this is really the target of most of our therapies, is the non-calcified plaque. And we know that younger patients, specifically if they have significant risk, like if they have diabetes or familial hypercholesterolemia, or in this case, elevated lipoprotein A, systemic inflammatory diseases, there's various conditions that we are learning more and more that they are risk factors for having more non-calcified plaque. The other aspect here is the low attenuation plaque. So again, a subtype of non-calcified plaque. And in this case, this represents 10% of the plaque. So that is a fairly large amount of non-calcified plaque. So on this slide here, I want to show you a little bit the AI, the interactive tool that we use to look at plaque. So specifically, if I kind of walk you through this video here, there's a toggle switch where you can go between FFRCT and plaque. If we're now in the plaque modules, we can go up and down each vessel. So right now the LAD is selected. And as we go up and down and you look at the right side of the screen, the plaque is color coded. We're in pink, and now we're shifting to the RCA, but same colors here where blue is calcified, the pink is non-calcified, and the purple is the low attenuation plaque. And we can, in a very interactive fashion, you can pick each artery, go up and down the artery, and see exactly where the plaque is. It's interesting here that you actually see circumferential plaque, and it's not common that you really see plaque going all the way around an artery. And of course, when I looked at this, I said, wow, this is a lot of plaque. And we go back when we see this and we say, let's look at the images. Can our eye actually detect this plaque? And this is really one of the powers of quantification, is seeing things that our eye can see, but sometimes not as well. So if we actually go back and look at the images in this specific case, here on the top is the LAD, on the bottom is the RCA. We can actually see this, low attenuation plaque. It's a little fuzzy looking, but we can see, as we're kind of doing it, the equivalent of a pullback through the LAD on this image here, we can actually see circumferential plaque in some of these portions here, and we see extensive non-calcified plaque. Same with the right coronary artery. When we kind of go through and look at this vessel carefully, we see an extensive amount of non-calcified plaque with very nice correlation between where we see the plaque and where it was actually quantified. So 10% low attenuation plaque, does that mean anything? And of course, I already hinted that that signifies a higher risk. But one of the big questions in cardiology, and I'm going to use lipoprotein A as a case point here, is can plaque imaging improve risk assessment? And specifically in patients with lipoprotein A, this is a very hot area now because there are therapies on the horizon. But when we talk about lipoprotein A and we evaluate the literature as summarized in this figure here put together by Arthur Shayovich, we see that an elevated lipoprotein A is associated not just with more plaque, but faster plaque progression, more high-risk plaque. It's associated with more abnormal lesions by FFRCT, more obstructive disease, a higher calcium score, and also low attenuation plaque. So basically all the bad things that we can see with CT have been associated with elevated lipoprotein A. So how do we put this all together? How do we interpret this case? So our interpretation in the report is as follows. There's extensive amount of coronary plaque. The total amount of plaque is 824 cubic millimeters. We indicated in parentheses that this is greater than 99th percentile adjusted for age and sex, with 88% of the plaque being non-calcified, and the low attenuation plaque represents 10%. The recommendation here follows the CADRADS guideline, and specifically this is a CADRADS 2. 2 means mild stenosis. Of course, we don't get too excited about mild stenosis on CT, but this is a P4. P4 is the highest category of plaque. As a reminder, In CAD-RADS, the P-score goes from P1 to P4. And when it's P4, our recommendation is referral for outpatient follow-up for aggressive risk factor modification and preventive pharmacotherapy. We now put this, by the way, in every report, the recommendation. So this is the utility of plaque imaging, is that we can get a more precise estimation of the amount of plaque, and this directly ties to our recommendations. So our take-home point is that quantitative coronary plaque analysis can provide a quantitative measure of the amount and type of coronary plaque. And by type, I mean the specific morphology that we talked about, which is non-calcified or low attenuation plaque or calcified plaque. The information can enhance coronary CT interpretation, refine patient risk assessment, and also help identify individuals who are most likely to benefit from aggressive preventive therapies. So I will end it there and turn it back to Jonathon.
Thank you so much, Ron. What a fantastic talk. We're going to have lots of time for conversation. I really look forward to it. I was taking some notes and formulating my own questions, but for those of you listening in, please enter your questions in the chat. We'll get to them after Dr. Gallagher's final presentation. Thank you again, Ron. So it's a real privilege again to welcome Dr. Gallagher. He's the Program Director of the Cardiovascular Disease Fellowship and the Director of Advanced Cardiac Imaging at Corewell Health, formerly known as Beaumont Hospital. He's a professor at the Oakland University William Beaumont School of Medicine. And like Ron, a dear old friend of mine, what you'll see from Dr. Gallagher is he's really not just a master CT interpreting physician, but also a master clinician. He's taught me so much about the integration of CT and how he uses CT to manage patients. And I look forward to your presentation, Michael.
Thank you, Jonathon. Thank you, Ron and Jonathon, and in particular, the Society of Cardiovascular CT and HeartFlow for giving us the opportunity to really share some exciting data and cases with you all today. And so my task today is just that, is to follow the really great lead-ins from Dr. Leipsic and Dr. Blankstein, and to share another case that highlights some of the advantages of plaque assessment. So I do spend some time working as a mentor or consultant for folks who are starting up FFRCT programs. So my case is a 52-year-old physician with a past medical history of hyperlipidemia and hypothyroidism. His father underwent bypass at 62 years of age. He was on a low dose of a low-intensity statin. I saw him in my office for intermittent chest pain. And the pain was typically at rest, but more recently associated with a left arm ache after playing hockey and sometimes while playing hockey. Of note, he had a stress echocardiogram a few years ago that was negative. His blood pressure was mildly elevated. His total cholesterol was 255. His LDL was 139, and his hemoglobin A1C was 5.6%. You can see his EKG fairly unremarkable shown here. So a patient like this who comes to me with chest pain in my office, or for that matter, to the ER with chest pain, we typically lean on a CT first strategy, and that's what we did in this particular case. You can see in the bottom, his right coronary artery has minor calcified plaque in the proximal and mid to distal segments. And more interestingly, in the LAD, in this eleocrania view, you can see fairly extensive non-calcified plaque followed by calcified plaque as shown in the cross-sectional regions. This was really felt to represent a greater than 70% stenosis in the proximal to mid-LAD, and this was sent off for FFRCT. And as you can see here, to follow Jonathon's lead-in, the translesional gradient was really quite unimpressive, from 0.99 to 0.92 across the lesion. The mid to distal FFRCT value is 0.9. So these findings suggested the lack of lesion-specific ischemia. So in summary, we had a patient with an LAD proximal to mid segment, calcified as well as non-calcified plaque with a greater than 70% stenosis, or a CAD-RADS 4A designation, but an FFRCT of 0.9 that suggested the lack of lesion-specific ischemia. And the plaque burden on the plaque staging system was a P2 to a P3. So with that, we treated the patient medically. And what I want to share with you is, if we look for a minute at what Dr. Blankstein shared with you, on the far left model of our interactive plaque assessment tool, we sent this data off for interactive plaque analysis. You can see the 3D model to view the FFRCT and the plaque on the left, as well as the total plaque volume on the left. In the middle, we have a straightened CPR that allows us, as Dr. Blankstein shared with you to track along the vessel to look at the FFRCT values, as well as the extent and type of plaque. And on the right, in this particular case, yellow is designated as non-calcified plaque and blue is calcified plaque on the far right portion of the screen. So if we put this into action, you can see that the FFRCT value is 0.92 distal to the stenosis. And if we then track up and down the vessel, and I bring my cursor back to the left main and proximal LAD, keep your eyes focused on the right and look at the degree of yellow non-calcified plaque as shown here, followed by blue calcified plaque. Fairly extensive non-calcified and calcified plaque throughout the proximal to mid LAD, with a plaque score alone in the LAD of 419 cubic millimeters. So this is our interactive plaque assessment coupled together with our FFRCT assessment, a negative FFRCT, but fairly extensive plaque burden. So if we take a closer look at that, as you saw before with Dr. Blankstein, we can actually summarize the overall plaque score. And this patient had a plaque score of 619 cubic millimeters, but again, similar to the last case, heavily associated with non-calcified plaque, with a non-calcified plaque score of 526 cubic millimeters. And if you look more closely at the colors, the designation, you can see I've shown you the yellow in the longitudinal vessel, the straightened CPR in the bottom correlates nicely with the short axis images. The blue calcification, as shown here, it's a nice color depiction of what we're looking at, both in long axis and in short axis, as well as a summary of the degree of plaque. So I had to put this all together. I saw the patient in my office after the cardiac CT and the FFRCT and the plaque assessment. And the decision was made to maximize medical therapy with a diagnosis of non-cardiac chest pain. There were several atypical features associated with the pain as well. And so there was no plan for invasive coronary angiography. However, of course, we needed to maximize his medical therapy. And so we worked on that. However, over the next 6 weeks or so, the patient had intermittent continued chest pain and ultimately presented to the emergency department. And the decision was made by the admitting team to proceed with invasive coronary angiography. So if we take a look at what the invasive angiography showed, in the left, you can see a 30 to 40% LED stenosis. And in the middle, you can see the hyperemic invasive FFR assessment after adenosine was 0.88 distal to the stenosis, which correlated very nicely with our non-invasive surrogate FFRCT. So both of these demonstrated the lack of lesion-specific ischemia. So this patient was diagnosed with non-cardiac chest pain. No PCI was performed, but as you can see in the bottom right, we did take the opportunity to put a wire down the artery and take a look at the artery, not only for invasive FFR, but also for intravascular ultrasound. And you can see this run pull back from the distal vessel to the proximal vessel on the bottom right. And we initiated medical therapy on this patient, but what I want to share with you is that when we look at that pullback and we look at the degree of plaque shown outlined in blue here, the calcified plaque, you can see it on the IVUS, the calcification in the proximal to mid LAD with lots of shadowing to the right of the calcification correlates beautifully with the plaque assessment. And then again, all the non-calcified plaque shown by the yellow arrows, nicely outlined again on the IVUS in the panels above and on the plaque assessment by HeartFlow in the panels in the middle. So a nice correlation of the type, the characterization, and the quantity of plaque with IVUS compared with CT. And it really does bring home some of the data that Dr. Blankstein shared with you about the REVEAL plaque study, because in this study, as you saw, there was as well as with Miami, there was an excellent correlation with the CT quantification of the characterization and the extent of atherosclerosis demonstrated by cardiac CT as compared to the reference standard of IVUS. And so our case was a very nice depiction of this. And so let's bring this back home and talk about how do we as clinicians integrate all this data into our practice and how do we manage the patient. And we need to put this together into a report. And Dr. Blankstein commented on this a bit, but I would share with you is that you've seen that there's an age and sex specific nomogram, as Dr. Blankstein shared, that we can now categorize my patient in reference standard to thousands of patients with a similar age and gender. And we can plug his age, type of plaque into a plaque calculator and determine that this patient's at the 84th percentile for the overall degree of total plaque, with a plaque score of 619 cubic millimeters. So now we have some objective data and a percentile. But as Dr. Blankstein also mentioned, it's so important in the CAD-RADS 2.0 system to designate not only the degree of stenosis severity, but also the overall amount of coronary plaque. And initially, it can be very difficult because this is a very subjective assessment. And this patient was felt to be between a P2 and a P3. It's very visual and subjective about the number of vessels or the extent with a visual assessment of the degree of plaque. And now what we're able to do is create staging systems. And this is taken from a registry that is looking at 20,000 patients, and they're stratifying patients according to their total plaque volume. And they're characterizing the mild plaque volume with a plaque score of 1 to 100, moderate 100 to 250, severe 250 to 750 cubic millimeters, and extensive greater than 750 cubic millimeters. And so what we've started to adopt is to actually classify this as our P1 through P4 staging systems. So now we have a relatively accurate, quantitative, and reproducible way in which we can characterize our overall plaque burden. And so now our reports will not only show the CAD-RADS 4A in this particular instance, but also can share the overall amount of plaque as based upon a plaque characterization tool with objective data. And I think we're really moving towards personalized risk prediction with these sorts of scoring systems. So let's get back to my patient. What did we do? Well, we treated him for his non-cardiac hockey-related musculoskeletal pain. He saw an anesthesiologist for injections of his thoracic pain. He was treated with a maximum dose of a statin. We added ezetimibe. His LDL was still above 70, so we added a PCSK9 inhibitor. He was initially reluctant to treat his blood pressure aggressively, but after seeing the degree of plaque in his arteries, he was agreeable to maximizing antihypertensives. We added aspirin, focused on exercise and diet, and we really started to think and talk about early treatment of borderline diabetes as his A1C started to increase on subsequent visits. So with that, I want to bring that home to some take-home points. And I think with this case, we were able to share the importance of FFRCT assessment to help guide decision-making, the importance of a physiologic map on top of our anatomy, the greater than 70% stenosis, but a negative FFRCT, very important for your clinical care. We talked about incorporation of plaque assessment tools to quantitate the degree of atherosclerosis. We really verified some of the data from Reveal Plaque in Miami about the accuracy of quantification. And we are able to calculate a patient-level plaque volume, integrate all that data into a report, and we can use that data to better inform our management decisions. So with that, I'd like to thank you all and maybe turn this back to Jonathon for a discussion. So thank you all.
Thank you. That was really a great overview. As I had thought, not only of the science and the data, but both of you sharing your clinical experience, which is so powerful, not just from a visual interpretation and a reporting of the CT, of course, but how you would manage these patients. And that's incredibly helpful and powerful for me personally, I know, and I'm sure for so many others on the Zoom. So let's welcome Dr. Blankstein as well back in, and let's have a conversation. I have a few questions. There's a question in the chat that we'll also address. But before I do, I think both of you highlighted the fundamental importance of tool validation. You know, we have a lot of tools in imaging. I'm a radiologist by training, as you know. There are many tools that are out there for lung nodule detection and stroke detection and blood intracranial hemorrhage detection. And one of the things that I like to teach our fellows and residents about is the fundamental importance of the hierarchical evidence required to integrate a tool. You know, the idea that you need to show that a tool is first reproducible and accurate. And then, of course, you can explore the risk prediction and clinical utility and then the prospective integration. But you both highlighted the IVUS correlative data of Miami, which comes from your center, obviously, Michael, and then the Reveal Plaque study led by Professor Narula, the largest international multi-center IVUS correlative study. And maybe as clinicians, you can tell me, you know, many people will say, listen, I visually see the plaque. I know when there's a lot of plaque, but why is accuracy important to you as it relates to understanding a tool before you integrate it into your practice? I know, Ron, maybe let's give Michael a break. Let's go to you. Why do you think those data are important? Why did you share that in particular?
Yeah. Well, I actually think in imaging, people are kind of obsessed with quantification and numbers recently. It's like a trend, you know, in MRI, we never had numbers, and now we have all this mapping. We give all these numbers. And then cardiac PET, the new thing is quantifying blood flow. In echo, there's various quantifications and strain. And I think the problem is that often we have a tool and it gives us a number, and sometimes there's a lot of overemphasis on some of the numbers. You know, people report, we report an EF to the hundreds. We say the EF is 47.52%. And I say, is it really that accurate? So before we start reporting numbers, it's really important to know what those numbers mean before we start putting numbers in report. What, you know, how have they been validated? What is the accuracy? How is it compared? And I think it's really important for imagers, because imagers, whether you're a cardiologist or radiologist, if you put that in the report, your referring physician will ask you, well, actually, what does this number mean, and how is it validated, and where did it came from? And then, of course, they'll ask you, and what do I do about it? But I think it's a really important thing as we're using more and more numbers. I kind of urge everyone to always question where those numbers come from and how are they validated. I think it's essential.
Yeah, that's a really good point. And you know, when I think about the utility of plaque tools, I know that I've tuned my eye to evaluate coronary disease, obviously over the last 20 years. And I know when I read a CT as negative, those patients generally do well. And so I think you highlight a very important point, particularly around the identification of modest amounts of plaque. If a tool is going to tell me there's plaque there, I'd like to know how well they agree with the intravascular gold standard at identifying or characterizing modest amounts of plaque, because, you know, it'll be perhaps contradicting my visual interpretation, and so I really have to have some confidence in that. And you know, maybe Michael, well, I'll ask you then. There's a question from the audience that I think is important, and there's probably not a definitive answer at this point, but it highlights an important, outstanding question for the field: is, you know, how do the different AI derived total plaque volumes correlate? And I assume the individual is asking, you know, across the different vendors, and you know, your thoughts about what sort of science we would need to do, or what would need to be done to try to answer this question, or if you don't think it's an important question, you can obviously share that as well.
No, I think it's a good question. And I guess the first thing to reflect back a bit on what Ron shared is that, you know, I do think this, you know, reproducibility and accuracy is very important. Even you and I and others, when we have intra and inter-observer variability, and even something as simple as a P0 through P4 staging system, I think we often may even disagree on that. And so I very much welcome this quantification to integrate into a very well accepted CAD-RADS 2.0 reporting tool. And I think it lends itself extremely well into a recognized and adopted reporting system. But I think as far as the question is, you know, different vendors have looked at the degree of atherosclerosis in correlation with intravascular ultrasound. And I think back a little bit to, no doubt, what Ron's quite familiar with strain imaging. You know, and strain imaging is very vendor specific, and there's some differences and subtleties from one to the other in terms of absolute values of strain imaging when you assess strain performance of heart function. And that's okay. We've learned to deal with that. It's not a deal breaker by any means. And it's something that we recognize as a scientific community, and we move forward and we use strain commonly. So I think we may have some of these lessons to learn as it relates to atherosclerotic plaque characterization, and that's okay. But I think we need to research it, study it, recognize it, and know how to incorporate it into patient care.
Great comment, great answer to the very challenging and interesting question. I mean, we have all sorts of issues. I know from the SCCT, there's been a real effort, leadership, I think that was under your guidance, Ron, but leadership from Drs. Neiman and Garcia around quantitative plaque imaging and CT, and sort of a guidance document highlighting the many opportunities, but also the challenges. I mean, I'm very excited about plaque quantification, but I'm also very aware of our history in cardiac CT. When we ran too quickly with cardiac CT in 2005 and 2006 and 2007, and we didn't necessarily have the evidence or the data, and we were really perhaps overly ambitious and excited, and we ate humble pie. So I think that, you know, the thoughtful integration of plaque is going to be very important. You know, acquiring the data appropriately, using CT in a thoughtful way. If we're doing tracking treatment response, we obviously need to visually inspect those CT data sets as well. So let me pivot back to you, Ron. You know, I was very kind of both of you to highlight George Seamus's work, you know, around the nomograms. Obviously, these are referred patients. It's not asymptomatic, so it wasn't intended to be, though. But you highlighted the importance of understanding the prematurity of plaque or the percentile of plaque. And maybe you can share some of your thoughts, Ron. Obviously, now 2 decades of thought leadership in calcium scoring. You know, many people will tell me, you know, it's just the burden of plaque. And obviously that's true at 2 years. If you have a truckload of plaque, you know, even if, and you have a very modest amount of plaque, even if it's premature, the person with a lot of plaque is more likely to have an event. But clearly the prematurity of plaque in a young patient may not be relevant at 1 year or 2 years, but I'm sure as a preventive cardiologist, that's quite important to you as it relates to their 10-year or lifetime risk. Maybe you can shed some light on those two elements.
Yeah, it's a great question, Jonathan. Really, it's like what's more, people ask this a lot, what's more important, the percentile or the absolute amount of plaque? And the reality is they're both important. So in the short term, whether it's a calcium score or CT, the overall amount of plaque you have, I think, is going to be the strongest predictor of risk. If you have a lot of plaque, you're always going to have higher risk. But percentile helps us identify folks who are kind of on the extremes better. So young individuals may not have a lot of plaque. Maybe they only have, you know, 80 cubic millimeters of plaque, but for their young age, it may be over the 90th percentile. And that's a reflection that's helpful both for relative risk. So I would tell that young person, relative to other males your age and your race, you are at a much higher risk. You have more plaque. So it's a measure of relative risk, but it also ties into long-term risk, somewhat analogous to the fact that many of our risk calculators in prevention really look at risk in the next 10 years. And now there's an effort to look at lifetime risk. It's the same thing. If you have plaque at an early age, I'm not going to be concerned about your risk of having an MI next year, but I'm going to be very concerned about your lifetime risk of cardiovascular disease, because I'll say if you're starting to have this much plaque at this age, you're on the wrong trajectory. So really important a concept. We have to look at both. The absolute risk, at least in the short term, is going to be the absolute amount of plaque, but the relative risk and the long-term risk, I think, is going to be more informative to look at the percentile.
Thank you. That's yeah, it's really exciting, and I think particularly if you're thinking prevention and understanding treatment response, it's going to be highly important, as you point out. A really great question to bring us home, perhaps, from both of you. Interesting question from the audience. Are there any studies investigating whether or not delineating plaques based on morphology using AI to predict which plaques may rupture and guide premature stenting? Well, I guess it wouldn't be premature, but maybe I guess it would be preventative stenting. I'll get both of your thoughts. I'll share for those in the audience. Recently, Professor Koo again published a very interesting study called Emerald-2, which was presented at TCT. It was published in JACC Imaging just about a month ago. And in it, he explored the complementary roles of stenosis, plaque morphology, burden of plaque, as well as hemodynamic forces as delineated by shear stress quantitatively using computational fluid dynamics, and also delta FFR. And interestingly, similar to the Emerald-1 study, it would appear that the delta FFR, the very measure that I highlighted at the beginning of the talk, was important to help identify a lesion that will derive benefit from revasc as it relates to angina relief, may also be a marker of a lesion that's at higher risk of rupture based on the mechanical forces of the lesional pressure loss. So I think there's certainly some real interest in complementing mechanical forces with plaque features in predicting downstream risk. But maybe I'll go to both of you, and feel free, either one of you, to speak first. But whether it's topological changes or features. We've seen a lot of work in radiomics or perivascular fat, or any other ideas you have how we can further try to refine our understanding of the vulnerable lesion.
I'll start by saying I think it's a very challenging concept. I think in cardiology, this term vulnerable plaque that was coined actually in my institution over 20 years ago is kind of been a holy grail both of non-invasive and invasive imaging. But the problem is that you need a very good positive predictive value, a good specificity to be confident enough to say, yes, that is really high enough risk that you're going to do something locally, a local therapy, a stent. In the reality, as I've yet to see data that tells me that. So I personally, and maybe I'm a little biased as a preventive cardiologist, I think of atherosclerosis as a systemic disease and a systemic treatment. And if I see a high risk plaque, I say we need to kind of double down on those preventive therapies and treat the patient even more. But I think your question, and I think the question from the participant is, is plaque imaging, is plaque morphology going to be able to make us even better to address that per lesion risk? And, perhaps I think it's going to require ultimately a combination of both imaging data and non-imaging data. I think I would combine it with, risk factors, with other things. But I think we're at least moving in that direction, that we're getting better and better at looking at those high-risk lesions. But it's still open to me whether we're going to have a high enough specificity. And ultimately, it'll be a trial that's needed to take folks that have what we think is a high enough risk and randomize them to a focal therapy versus not.
Yeah, really thoughtful comments. I'll let you bring us home with your thoughts on that, Michael. But what I always tell people when they ask me this is that it's not been achieved with intravascular imaging with all the spatial resolution and image fidelity. But I am excited about the ability to, of course, take all these tools and apply them to the question, to a non-invasive data set in a unique way, right? As you mentioned, whether it's mechanical forces or plaque or fat inflammation. Now, Michael, did you have anything you'd want to share on this topic?
Sure. Thanks, Jonathan. Yeah, I think I would maybe add on to what you mentioned about, Emerald 1, Emerald 2 paradigm study. Some of what even Ron shared about Scott Hart and the low attenuation plaque and the 7-fold increased, risk prediction for folks with a plaque score greater than 4% or a cubic plaque volume of more than 238 cubic millimeters. And what I've enjoyed is looking at these studies when they look at all these AI-enhanced features, including the pericoronary adipose tissue inflammation, as you described, the PCAT. When you look at that total plaque volume, atheroma percentage, low attenuation plaque. When you look at those features as calculated by AI, when you look at the incremental improvement above percent stenosis, absolute FFRCT, traditional risk factors that we all grew up with, when you look at any clinical traditional risk factor, and it's quite striking that these AI variables stand out time and time again in these trials that look at 1 and 3 year cardiac events. So I think it's very provocative. I think it's early, but I am very excited to see the complementary role of looking at AI enhanced features together with the standard clinical risk factors, as well as the time-tested percent stenosis and FFRCT. So it's an exciting topic.
Excellent. Well, let me take this opportunity then to thank you both, to thank obviously the SCCT. The professionalism of the staff is really amazing. As you may know, I was the president of the society in 2015, and to see the maturation of the society and its development has been a source of great pride. I had very little to do with that, but nonetheless, I derive great pride, and I'm so grateful to be part of this society. I want to thank the team from HeartFlow for sponsoring not only this webinar, but continuing to support the SCCT. It's obviously a fundamentally important society to our field and to the patients that we serve. And finally, Mike, let me close with a big expression of gratitude and thanks to my dear friends, colleagues, and in many ways mentors, Doctors Gallagher and Blankstein. Really always a pleasure to learn from you and work with you. So thank you again. And to all of you who joined in, thank you for joining and for sharing your thoughts. All the best, everyone.